Okay, so good morning, everybody. Can we start? I think we are all set. So welcome, everybody, to the AmCham Healthcare Annual Conference in Estonia. My name is Elo Tamm. I'm the chairwoman of the Healthcare Committee and really happy to welcome you all. The aim of AmCham Healthcare Committee is to bring together the international expertise and local policymakers. So we are really thrilled to have such an expert panel of international speakers and the top Estonian policymakers here. So we are really looking forward to the discussions today. This conference has been an ongoing one. We have had the conferences since 2017. So we had a small kind of different kind of a format through COVID years, but basically it's an ongoing tradition, and we hope to continue those discussions with the policymakers in Estonia for the future to come. So thank you very much to our international speakers for flying in. We have really an expert panel coming up. Thank you for the policymakers to coming here. And thank you to all the sponsors. I mean, we cannot make this event without the sponsors. So thank you very much, platinum sponsors, AstraZeneca and Roche, gold sponsors, MSD, Johnson & Johnson, Medtronic and Pfizer, and silver sponsors, Sorainen and Chemifar. So I think we are all set. We are also viewed online, so welcome online audience as well. You will have the materials later on, so no need to take the notes of it. But without further ado, I would introduce our first speaker, and this is Michael Gutterbock. He's the senior consultant at Economist Impact Health Policy Team. He works with global clients developing and delivering evidence-based health policy projects across a wide range of priority areas and manages Economist Impact research teams. Prior to consulting with Economist Group, Michael worked in disaster preparedness and humanitarian assistance consulting, as well as policy design and implementation with the US federal government. He holds a master's degree, many of them. First one in international relations from Johns Hopkins University, then a master's degree in global health from the University of Michigan, and currently is pursuing the doctorate at Johns Hopkins. So we are really happy to have you here, Michael Gutterbock. Please, the floor is yours.
Thank you. Hello, everyone. Good morning. Is it working? Okay, great. So as you can probably tell from my accent, I'm an American. I'm living in Italy, and I'm now in Estonia, so it's all a bit confusing, but here we are. I'm very glad to be here, and thank you very much for AmCham and to the sponsors for having me. So today, I'll be talking about a report the Economist Impact did on Central and Eastern Europe, called At a Turning Point, Healthcare Systems in Central and Eastern Europe. The initial report did not actually include Estonia, but we have added some Estonia information, and a lot of the findings are completely relevant to the Estonian context. So the background of this project was that, so as I mentioned, it's called At a Turning Point, and the study was conducted by the Economist Impact. We had the editorial control, but it was sponsored by AmCham, and it highlights some key differences and commonalities within the healthcare systems of Central and Eastern Europe. The key objectives were first to raise awareness on health system dynamics in Central and Eastern Europe, to generate the latest data and insights on health system financing, available resources, and the provision of care, and also to identify priorities and act as a call to action for the selected Central and Eastern European countries. So, as you know, lately healthcare systems, especially all over the world, but also in Central and Eastern Europe, have undergone a lot of strain, a lot of different changes. So first, of course, is the aftermath of COVID. there have been higher COVID-19 related mortality rates in this part of the world. And there's also been a decline in healthcare spending post-COVID, and also a lot of workers in Central and Eastern European nations that work in the healthcare system have actually left the system due to burnout, low pay, and other reasons. So also, of course, something that affects this region stronger than anywhere, perhaps only Ukraine, the war in Ukraine. So it's contributed to rising energy costs, increased need for defense spending, which of course can take away money from healthcare spending. And then there's also been, as just happened yesterday with the attack on the cable, there's been some kind of gray zones and hostilities that obviously weren't the case before, but now put strain on the system. Also, so as I mentioned, the higher allocation of the national budget for defense, and Estonia, as far as a percentage of GDP, I believe is one of the highest putting towards defense, which means less money for other areas such as healthcare. So also, there's also the shifting EU policy landscape, which is affecting the healthcare systems. So there's serious cross-border threats to some health regulation, as you probably know. And there's also different programs that the EU is doing that affect the system in these Eastern European nations, and some of which they're not quite as adapted and ready to be able to implement them. So spending on healthcare is lower in Central and Eastern European nations compared to some of the Western European nations. The link between health and wealth overall, as you know, richer countries tend to spend more on healthcare. So Estonia spends actually 1,565 euros per head on healthcare, which is significantly lower, half of the EU 27 average. And that is widely on par with the other Eastern European nations as well. But you can see where Estonia is here. So also some of the model, one key difference in Eastern Europe compared to some Western European countries is the way that healthcare is funded. So you can see the model here, the model of funding in healthcare is no longer sustainable in the face of changing demographics. As you know, Eastern Europe is aging, maybe perhaps not as rapidly as some Western European nations, but it is aging rapidly. And so the current way that healthcare is paid for, which is there's a large chunk that is out of pocket, is not necessarily sustainable. So as you can see in Estonia and Latvia, it's well above the EU average at 20 or 30%. It's well of out of pocket. It's well above the EU average of 14.5%, which is a significant strain on people's pocketbooks. So how money is spent and how efficiently also has an impact on the outcomes of resource optimization. So there's a legacy here in some of these countries of hospital-centric care, and it still dominates a lot of care. People think that the hospital is the place where you get the medical care, so there's not as much of a thought about the preventative care and other means for engaging with the healthcare system. So Estonia, you can see, actually has 4.5 beds per 1,000 population, which is lower than the EU average of 5.3 beds. It's obviously a little strange to have 0.3 beds, but you understand it's an average. And the Central European and Eastern European countries, they allocate less resources for preventative and long-term care, which is, of course, something that maybe you do not see the negative impacts immediately, but in 20 years, 30 years, you see the negative impacts of lack of preventative care because people are sicker when they do finally engage with the healthcare system, which is honestly often in the hospitals. They're much sicker and more expensive to treat. And as I mentioned before, there's also a huge problem with workforce shortages. So workforce in a lot of Eastern and Central European countries go to other countries where the pay is better. And there's not necessarily backfill. And as I mentioned with COVID, a lot of workers in the healthcare system left the system because of strain. So the CE countries actually also lag behind the rest of Europe as far as patient access to innovative technologies, which I think this group knows well. And so according to to some, the Baltic states, 40% of CT equipment is 10 years older, almost double the EU standard. So a lot, and that's just one example, but there's a lot of equipment that is very old and maybe doesn't work well, and some of it is even at this point difficult to find parts for. So that is a huge problem. And the Baltic countries, this is a very glaring statistic to me. Baltic countries, 13 to 18% of innovative medicines are available. So that's much lower than the average of 45% for the rest of the EU. And this is a huge effort. This is something that very much needs to be addressed, not just in Estonia, but in most of Eastern and Central Europe. The speed at which some innovative technologies also come available on the market here is much slower than in Western Europe. So the COVID pandemic showed the need for rapid digitization of the healthcare sector, and this is actually one area where Estonia is, I would say, held up in some cases as an example of being digitized. But as I was speaking with some of my colleagues yesterday, there's still a lot of work to be done. So you can see here, this is interesting. Estonia outpaces as far as digitization, even Germany and some of the much more wealthy countries in Western Europe, but there's still work to be done. And I think there's some basic connections between the digitization and the health data that can still be made, even though Estonia can be used for as an example for other countries in this space. So you can see Estonia is an outlier among a lot of the countries in the CE area in terms of digital adoption, ranking #1 in access to digital public services. But as I mentioned, some of my colleagues were saying that in the health, that may be true in general for public services, but not necessarily as true in the health sphere. So there is some room for improvement. So Europe is also making a huge push to try to digitize health services. They had the digital decade, which is a target for all public services to be fully online by 2030. And some countries are doing better in this effort than others. So this is another area, as I mentioned, that is open for improvement. So kind of the call to action of this report, and some of the 5 key takeaway areas that I think are important to highlight. First is the provision of healthcare investment. So policymakers need to see healthcare as not something that pays dividends immediately, but as a long-term goal, long-term investment for the good of the country. And I know this is something that, with the current situation in Ukraine, is very difficult to convince sometimes, because something seems like an immediate threat, whereas the healthcare issues don't seem as immediate, but long-term, they really are obviously something that needs to be addressed. So to prioritize additional provisions in the short term, as I mentioned, and then to commit to multi-year strategic plans that see things and actually kind of save budget pieces so that these plans can be implemented in the future. So number 2, the call to action is the transition to alternative healthcare financing models. So diversify revenue streams through taxes, reduce the reliance on out-of-pocket that's not necessarily sustainable, and improve efficiencies on spending where possible. And there are areas where this can be improved. And now for the third, strengthening prevention and primary care. So this kind of goes along with seeing healthcare as an investment, but develop a strong integrated network of primary care, community, long-term care, not just hospitals. Try to get people in for preventative screenings, preventative medicine. Prioritize investment in primary community care services, more smaller clinics in neighborhoods. People know the people, the workers there, they can go in more readily, more openly. Number 4, is to improve access to innovative technologies. So again, Estonia has come a long way in this and actually can be a model in some cases, but still has room for improvement. So to understand the root causes between inequalities and delays in access, and explore pricing models that reflect value of innovative medicines. So, and the last is the investment in digital infrastructure. So Estonia has done some great things in this regard, but the goal is really to develop digital capability and capacity at the regional level, and also to take advantage of EU funding as needed, because the funding from the EU is coming. Sometimes strings are attached, but I think there's a lot of ways that you can use this funding to help with the digitization. and then create a system that is ready to accept and implement advanced technologies, which is definitely possible. So that is the speech for today. So thank you, and I'm welcome to take any questions.
Thank you. We have room for questions. So any questions from the audience? Okay, please.
From Amgen. I have a question to you. You showed in this last slide that one of the options for improvement is healthcare technology assessment implementation. Would you have any advice? Because I think Estonia is a good example of implementing this technology assessment, but then the threshold is so low that on contrary, it doesn't improve the access. So do you have any recommendation, or specifically from some country, how to move forward? Because the current way it is in Estonia, it prevents innovation from entering.
So sorry, if I understand the question, you're talking about the new technology and then it actually being implemented for the
drugs, for the medicines. Mm-hmm. And then there is some willingness to pay threshold, right? So authorities saying that we are willing to pay 40,000 euros per one quality adjusted life year. And this is very low, because when it was introduced back in 2011, it was equal to 3 GDP. And now it's too little. So what would be advice, when you have system in place, but the threshold does not allow innovation to go through, because it means eventually, you have to squeeze the prices enormously. And, for innovation, this is not the way forward.
Yeah, that's a good question. And I can't actually think of an example. I can't think of an example that other countries that I know of that have implemented this. But I can look into that and get back to you. No problem. You can give me the contact. I can look for an answer.
Any other questions? I guess this GDP question is very relevant, because indeed we're checking at the GDP data, and it's not 40,000 that it should be 3 times the GDP. Our GDP is already around almost 30,000, so it should be increasing a lot. Andreas, you have a question as well.
Sure. Apologize for not standing up for notes and so on. So we touched upon this last night a little bit as well, but the question of positioning healthcare as an investment in the context of actual daily politics. Do you know of any, say, EU member states or other democratic countries where fiscal planning, whatever the framework is, a 1-year budget or a 4-year budget strategy, is able to look at healthcare spending as investment and take into account additional revenue accrued from, more better healthy living, additional hours, days, months on the labor market, and so on? Thanks.
Yeah, so for a European example, I don't know one, but I know in Japan and South Korea, they have programs that specifically almost benefit people who are doing some of the more preventative care, and they do it in a way to where they get benefits, both monetary and others, to increase their access to the healthcare system and along the preventative stages. So I think those are more examples than even in Europe.
Mm-hmm. Okay, thank you so much. Any other questions, discussions? Michael will not be joining for the panel. Rest of the people will be, but we will continue with this discussion. So thank you very much, Michael, for this presentation. Next, we will go on with our speakers from McKinsey. So we are really happy to welcome Lars Hartenstein first. He's the and Ulrike Detjen as well, but let me introduce Lars first. Lars is the co-leader of the McKinsey Health Institute. It's a non-profit generating entity within McKinsey, established to drive progress in health, help people live longer and improve their quality of life. He's passionate about advancing societal impact by bringing together stakeholders from a range, variety of sectors to collaborate on solving complex projects and bringing opportunities to life. He's the executive chair of the Societal Impact Financing Initiative and on the steering committee of the Trinity Challenge, a coalition established to improve the use of data and analytics in response to health emergencies. So this is Lars Hartenstein, very welcome. And we will have also Ulrike Detjen, who is the partner and co-leader of McKinsey Health Institute. She is passionate about building health ecosystems, lead health business building globally, and with an aim to advance health prevention and promotion over the coming years. She has also been involved in Estonian e-prescriptions many years ago, so some touch with Estonia as well. So Lars and Ulrike, very welcome to our conference, and the floor is yours.
Very good. So thank you very much. And as you just said, today is really a bit like coming home, because I've worked on other prescriptions actually in the past in Estonia. And therefore have a lot of admiration for what the country has achieved, coming from Germany, where e-prescriptions are just now coming into existence in 2023. And what I really admire is how there was a clear vision and a clear leap forward to that. Secondly, how health was really seen as part of a whole beyond the confines of the medical care setting. And lastly, how there was really a vision for economic prosperity as well. And these three themes are also what we want to talk about today, because it's about prioritizing health in all facets of everyday life as a key to economic and social well-being and prosperity. Because if you think back, then at the turn of the last century, 6% of deaths were only from chronic diseases. The rest was all acute. And in the meantime, many things around vaccines, sanitation, nutrition actually really improved the health and saved millions of lives. Now that 6% that I just mentioned have actually today risen to 66%. So 2/3 of the deaths are now related to chronic disease, which really changes the way how we think about health and how we also need to really think beyond the confines of the medical care setting. And also the policy debate has been, especially in mature economies, has been very much around reducing costs as one of the levers, right? But really this idea of investment into health as a way for prosperity, as a way to expanding productivity, as a way to extending the labor force, that is really a perspective that is very crucial today. And it's with that in mind that also the McKinsey Health Institute, a global non-profit organization of McKinsey & Company, has been founded. The mission is very simple. It's adding years to life and life to years. Adding years to life, life to years, right? So it's both kind of extending lifespan, but it's also about health span. Because if you look at it, then, and that's true actually in Estonia, but also in many countries around the world, in the 60s, the average life expectancy was around 54 years. Now it's about 73. So you see an average increase of 19 years. However, if you look at health span, then actually you see that Well, there's parts that we spend in good health, some in moderate, and some in poor health. But the proportion of lifespan and health span hasn't really changed in the same way. So now we still spend around 50% of our lives in good health and 50% in bad health, or moderate and poor. So that is something where we collectively, as the McKinsey Health Institute, have calculated that altogether we can actually extend our lives by 45 billion years collectively. So that's about 6 years for everybody in the room, more for some populations. So if you think of cities, for example, like Chicago, where the difference between the lowest or the worst postcode and the best one is about 30 years in life expectancy, then you can imagine that in different populations, the potential is really huge. So let's look at a couple of things more closely for Estonia and also for other things that we can do.
Yeah, so very exciting to be here today. So there are going to be a couple numbers I always call out specifically when it's about Estonia. Just maybe one add, what Ulrike has just said, I think it also resonates personally with me, I think with many of you. My grandparents, my grandfathers died at 70 approximately, at conditions that they wouldn't have to die of today necessarily. And my father is much older already and has a chronic condition. And my mother is afraid of dementia. She's still doing well. So that's a little bit the predicament that we find ourselves. Yes, living longer, but we are suffering quite a bit, proverbially, to get these additional years of life expectancy. Now, Estonia. So we have here, I'm just going to read that in Estonia, healthy life years have only increased by 0.9% in the last 5 years, and for women actually decreased by about a year. So that's numbers, and it's come from various sources. I would like to say one has to take it with a little bit of a grain of salt, right? Because these kind of, as COVID, there are special effects and so forth. But I think one thing is clear with all the things that Ulrike has just said. Estonia is not in a different place, maybe more advanced on digital health, but this struggle with lifespan, health span is definitely equally valid for Estonia as well. At the McKinsey Health Institute, we really focus on health as opposed to health care. And to really do better, we believe that it's important to embrace a modernized definition of health. If you look at where resources go currently, it is very much focused on, it's really focused on physical health. That's where 90% of resources go, and where most of the endpoints are in research. We asked 19,000 people in 19 countries, and they actually value these 4 dimensions of health, mental health, social health, and spiritual health, equally or almost equally to physical health. However, not at all how resources are being allocated. And also there are a lot of interdependencies between these dimensions of health. Just a couple anecdotes. Loneliness increases the risk of death for heart failure patients about 4-fold. That is an extraordinary number. So loneliness as a dimension of health and as a driver of ill health, very, very, very important. Mental health we have no data on mental health in 100 countries on mental health of youth and adolescents. So many of these areas hugely neglected, and about mental health, 1/6 of the resources goes into it per DALI or per whatever measure of mortality you have, as opposed to physical health. So now, if we take such an expansive perspective, then we have to also ask what is actually driving health. There are similarly, I'm talking about health, not health care. Of course, very important drivers of health are, healthcare, vaccination, detection. You see it here in the lower right-hand corner. Those are very important drivers of health and healthcare. When we look at really where are the modifiable, evidence-based drivers of health, we identified the 23 that you see here on the map. And they include things that are not surprising, like diet and exercise, but also sleep, the content we consume, also the social interactions we have, exposure to nature. All of those are evidence-based, highly modifiable. So I say that's incredibly good news. So if we want to improve health, there's actually a lot of evidence-based measures and levers that we can use to get there. So maybe given that we're here in the Nordics, I call one particular. If there was an intervention where you knew it would reduce your risk of mortality by 40% and reduce your risk of dementia by over 50%, would you like to know about it? I see some nods. Would be good to know about it. So there's growing evidence that actually regular use of saunas at high temperatures do exactly that. So if we say this outside of the Nordics, this is kind of usually seen as a light-hearted comment, but it's actually true. I couldn't believe it when I first saw it, but the evidence is actually strong for exactly that. And so then the question is, what do we do about that? If we are following the evidence, resources should be following the evidence. So anyway, I leave that for thought as we continue the conversation. So now to bring about this kind of fundamental shift, I will not be surprised that some things mirror what actually my colleague from The Economist said before. It is only possible to get to these substantial increases in health that the McKinsey Health Institute was also founded for if we really focus on number one, promotion on prevention. So the funding in maybe slightly higher here in Estonia, but like all very low. In OECD average, it's about 3%, European average about 3% that goes within the healthcare budget. Now we're focusing on healthcare into preventative measures. So that would need to be increased substantially. The second shift is really data. I spoke about this modernized conception of health. We are not measuring it. We are not having a positive functional definition of health. We are not measuring knee flexion until there is a knee surgery. So even on a physical side, we have no conception what our physical function is. We're really looking at it from a disease perspective. So we would need much more data on our health, on the functional status, be it mobility status, sexual activity, be it our resilience. Those kind of dimensions of health are not currently measured, and if we don't measure them, we also can't optimize them. Number three, and I'll talk about that more in a second, I'll say that is scale what works, right? Number four, innovation, that Ulrike will speak a little bit more as well, and I'll touch quickly on shifts 5 and 6. Number 5, really fully mobilizing the private sector across all industries, also outside of healthcare. Every private sector company is involved in health, at least as an employer, but many also because the products and services they offer have a direct or indirect implication for health. So there's lots of opportunity there. And lastly, of course, the individual. We were yesterday in a very interesting event just before coming here where somebody from the Singapore Health Board spoke about the measures that they are taking with mobilizing all individuals to, in a step challenge in that case, where there are 1.8 million out of 5 million or so involved that have increased their mobility by 50%. Extraordinary what is possible by empowering individuals to steward their own health, and maybe also related to the digital pre-investments that you've already done here in Estonia. So now let me focus on scale what works. What does scale what work mean? I spoke now about health. Health in a positive frame. How can we do better? How can we optimize health beyond only kind of avoiding disease? Now let's really focus narrowly on health, more healthcare, and scaling what works in order to avoid disease burden. Right? That's a little bit more the traditional frame, and it's, if you want the first step, there we need to go. So scale what works. So now some Estonian numbers. 32% is a potential to reduce the health burden in Estonia only by scaling proven cost-effective interventions. That is based on a large-scale, very well-received and proven model that is called, was published also in a report prioritizing health. Very happy to share that. There's a lot of detail. I can't go into all the details now behind it. And a second striking one, if we look at 2040 as a time frame, there could be 34,000 additional Estonians alive by that time frame. So, like, depending on what kind of person you are, do you like to focus on people, 34,000 people in addition as a goal, or a reduction of the disease burden by 32%. So how do we go about this? So 70% of this is linked to largely preventative interventions. That does include secondary prevention, to be sure. So what is part of this? Part of this is, of course, structured diet and exercise programs for that are proven and actually work for high risk individuals, smoking cessation, and also secondary or primary prevention, preventative medicines for heart disease, stroke, and diabetes. So the entire cardiovascular complex, for example. So those are just examples. So all of this highly cost effective, just scaling what works. 32% of the disease burden, very much preventative in nature. So if you can get at 32% with scaling what works, innovation, what is with the rest, right? So innovation in a classical sense can get to another 6 to 10% of the disease burden by 2040. And here just a couple highlights of the areas of innovation where those are, let's say, near to market innovations where we can already foresee now that it will happen. So this is not like speculation. This is based on analysis of pipelines, of already early data on new products that work and so forth. So this is really what we can reasonably expect over the next 2040 without additional breakthroughs or so that we don't know about at this moment. So in the typical areas are, really understanding what is the cell and addressing this. Technology that you may have heard about is CRISPR, this gene editing technology. That is one of those areas. And then next generation drug development. Maybe The Economist, the main magazine, speaking here to my colleague, had a technology quarterly on healthy aging, purely from a, let's say, innovation perspective about 2 weeks ago. Very interesting, very good, let's say, survey of how diseases of aging may be addressed in the future through new modalities. Digital therapeutics, perhaps also very interesting here, particularly relevant also for empowering the individual to be better stewards of their own health. Fascinating opportunities there in terms of how to use the data and maybe not only use AI, not use only AI to have personalized prescriptions or personalized recommendations, but also using large language models to actually better address and speak to the individual to make sure they're actually following these recommendations. Anyway, so there are a couple more innovation areas. We overall have identified 10 of them that we can expect. So now to business, because the tricky thing about health is always crossing the people and health perspective with a business perspective, with an economic perspective. So if we put all of this together with a 2040 perspective, what we can expect is 5 billion of additional GDP, which is about 11%, which is the same of adding approximately 0.6% to economic growth from now to 2040. So that is the return on investment argument for health. For every dollar invested in health, the return in Estonia, we estimate around $2.4 for every dollar invested. So now let's look at these 5 billion a little bit more in detail, because that's a very important number. So I'm now going to look at it from 2 different angles. So one angle is here, the base case. You have base case GDP to which you add 5 billion in terms of additional growth. So the drivers of this are really those 4 on the bottom here. So fewer early deaths if you address these interventions and scale them. fewer health conditions, so therefore this population can be more productive, therefore expanded participation and increase in productivity overall. So it's these 4 different levers that add to this this additional growth. So this is not at all taking into account like the idea of being a lead market or so for innovation. That's a completely different topic. That's literally only by scaling the interventions that we already know to work. And that, of course, translating into the growth differential here of 0.6% from 2.3 to 2.9. Of course, you can debate whether you would believe yourself that the base case growth is 2.3%, but over a 20-year period, that's very much in line with consensus what we can expect. So I promised different views on the 5 billion. So the second view here is where do these 5 billion actually accrue? So what we see that 70% of this GDP potential is concentrated in unleashing the power of healthier 40 to 70-year-olds. So just to kind of, this is for me a little bit like the Ministry of Finance chart, right? So on the lower side, you say the additional healthy life years, right? And that's, by the way, always a little bit the crux, because you see that those additional healthy life years are also peak at 80. Yeah, from a Minister for Finance perspective, like, or let's say from an accounting perspective, from a GDP accounting perspective, right? This is not so relevant. It's the other age group. But you have at the same time, by pulling these interventions, a peak at around around 70, where you're at 60, where you basically are still in productive age and are still contributing to the economy. So the same interventions massively add life years and health span over the age groups, but they also add additional GDP by making the population between 40 and 70 substantially more able to contribute and also less costly to society. That is the perspective on scale what works. Now we're going to innovation.
Very good. And I think talking about innovation, I mean, I could probably talk about all kinds of innovation until 12:30, and then the conference is over. So we actually decided to just focus on one part that I think is also particularly relevant for Estonia. And that's adding actually to today's healthcare market. On the left side, you see the conventional healthcare market, right? So hospitals, all kinds of things in the classic medical confines. Now, there is an increasing emerging health-related market, and it goes hand in hand with that shift that Lars described of kind of taking the much wider perspective of health beyond the physical aspects, taking the 23 drivers of health that very much go into everyday life, how we eat, how we sleep, how we move. If we take these into account, then there's a whole lot of an emerging health-related market that is about the same size. Now you see it's still quite wide in terms of the overall measurement because it's developing. But what is quite clear is that only about 20% of that market is tapped today, and it's tapped with things like wearables, right? So I wear my ring every day and see how I sleep and how I move and what I should do. But it's also a whole lot of other things around well-being, nutrition. And if I just look at the conversations that I've had over the last 3 years, well, over the last 10 years, it was very much on this side. Over the last 3 years, it was retailers reaching out, asking about health. It was telco, it was insurers. So very much kind of organizations that wouldn't necessarily be part of the classic healthcare market, but that now realize, wow, there's actually both something that we can do from a social perspective, but there's also a business opportunity for these players. And if I think of it, in terms of what is actually needed in order to drive innovation within the country, then we usually say there are 3 different aspects of it. The first of all is you need certain catalysts. That can be things like e-prescriptions that we already talked about, electronic health records, so everything that is infrastructure in the health system. Secondly, there's orchestration, so getting different players actually to work together, because a lot of the things that we talked about today are things where the incentives are not always perfectly clear. So if an organization actually wants to do something, for example, around health prevention, they're not necessarily the ones reaping the benefits. So it's about orchestrating the different players. And it's about a clear roadmap. So really having a view and a vision for where to take the health system. And now that actually leads to acceleration. But what I really like about this is, and I've had several conversations actually with Estonians over the last days, where we also said, well, maybe some things are not perfect yet in the health system, but I think if you take perspective, and I'm taking the perspective here from outside of the country, then I think there's lots of good things that are already there in terms of catalysts and in terms of orchestration in a small country that has a very strong infrastructure. And it's about developing a clear roadmap for the things that are ahead. And what can that roadmap be? So let's just take the perspective of an individual. Let's say somebody's having a problem, they're using a symptom checker, then actually that symptom checker shows that they should talk to a medical professional. So they're actually kind of either getting help through telemedicine or using an appointment booking tool in order to see a doctor. They're actually picking up, potentially enhanced through remote diagnostics, potentially afterwards picking up a prescription and filling it. So the white parts are digital services that are being provided. The blue ones are rather in the conventional healthcare system. Now think about it from the perspective, and I know we have many pharma companies in the room here, think about it from a data perspective, right? Just bringing together that data from what problem did this person have at the beginning, what was actually the diagnosis, what was the medication that was prescribed, and did the person actually adhere to it? Just using that data for a whole lot of aspects around drug development or around real-world evidence, I think the potential is huge. Similarly, actually, from the perspective of an insurer, it's actually interesting to evaluate what works and what doesn't work. Because if you bring together that activity and outcomes data from the various players, so can be tech players, can be startups, can be various organizations, so the new business or the new market is the upper part here, and the classic healthcare system is the lower part. Then if you actually bring these together with the many digital contact points that you have on the upper part, but like very few on the lower part, and you actually bring together what did this person do? For example, did this person use a certain digital service? And what was the outcome of it? So did this person go to hospital afterwards? Then you can also reimburse accordingly and thereby create new incentives for players to really innovate. Because today, and I think that's the same in Estonia and in many other countries, these digital health startups, for example, need to live off the $1.99 from the App Store, which of course is not the way to really create the right incentives to develop things that really work and really make a difference. So that just as a perspective of one particular aspect of innovation that I think can be quite relevant from a public health perspective, that really changes the way we look at healthcare in everyday life, and that really can change the system towards more innovation rather than just innovative technologies, which of course are very much at the heart of medical advancement. Now to summarize, what does it actually take on the way forward? First of all, it's really taking that perspective that we talked about over the last 30 minutes, right? The health perspective, but really also the social and economic perspective, and always having the view on all of these. The second, transforming healthcare systems. And healthcare here deliberately is in brackets, both because it's not only healthcare, but really health, and both because a lot of the health improvement that we're talking about today doesn't happen within the healthcare system. It happens in everyday life and how we lead our lives. Now, keeping health on everybody's agenda, that is really extending it to new players in the health system. So not just the classical providers, but going into retail, telco, and many other organizations that also have various touch points with individuals. And finally, doubling down on these innovations, the one that I talked about, but also the various technologies that are being developed in the world, where I think Estonia can certainly also play an important role. So with that, thank you very much. We're open to questions if we have time, but otherwise we're also going to be around for the panel later.
Thank you so much. If there are any questions right now, go ahead, please.
Thank you very much. Does it work? Hi. No.
Yes.
Yes, we can hear you.
Thank you very much. Indeed, very interesting. And of course, in Estonia, we would like the economy will grow and anyone will benefit. My question relates to the age of a labor force. What you showed that from the healthy life years, from 40 to 60, it's really there is a lot of potential. What you will see the role of the employers there and the role of the occupational health. In Estonian system currently, occupational health is a separate system, not so much bounded with the GP and the general healthcare because it's paid from the private money. And if the employer supports employees' health in some ways, then I would say we are punished because we have to pay additional French benefits. So what's your opinion on that?
I can take that one. So first of all, one disclaimer, I'm not an expert on the occupational health system in Estonia. Generally speaking, occupational health focuses very much on cutting off the bottom of the distribution, avoiding the worst events, right? All because of like some safety measures, so to speak, to making sure that there's not a cardiovascular event kind of around the corner, yeah? So it's very much focused on, let's say, the more traditional conception, avoiding physical health injuries and problems. So therefore, I think in terms of the role of the employer, what we believe is necessary that employers are getting more, also adopt a modernized conception of health, have a more 360 perspective on health, including mental health, burnout, the role of a toxic workplace environment for health. So these kind of elements are critical, and what is happening at the workplace impacting people's health, right? So I think changing that perspective rather than the very focused and very legitimate focus on the occupational health agenda. That is a part of it, of the role that the employer can play, but not the entire one.
And what we see is that it plays a more important role as an employer value proposition as well. I mean, in countries like the US, where it's always been like employer focused, that of course has always been the case, but also in countries in Europe, for example, where more than 50% in a recent survey have actually said that this is important or very important to them when they actually choose an employer. So I think that's an important aspect for that as well.
Any other questions? Okay, go ahead, please. Please wait for the mic as well.
Hello, Edgars from Medtronic. My question is about innovations and the correlation of innovations and some fundamentals like health expenditure. For example, we know that high spenders on health are also good at creating and exporting medical technology when we talk about such countries as Germany, Switzerland, US. Sometimes, actually very often, people look at them and comment that they are not very efficient, they spend lots of money, people are not, so there is no equity and there is no efficiency, but it looks like, and maybe you can comment a bit on these correlations, that if you have fundamentals, if you have high health economy in general, and primarily it's budget spending on health, you also good, really strong and really developed industry with huge value added. One of the biggest value-added industries and exporters. So can you comment on this a bit? Thank you.
So I think there are two different, let me frame it slightly broader. The question is like, how can you become a lead market for health, right? So I think, and that definitely has to do with resources. Now, the resources can come from different areas. There are different types of lead market that one can be. There are the resources of the consumer, of the individual out of pocket, as well as what they're spending as consumers on health-related one, and the budget, right? So overall, of course, if you want to be a lead market for a area of technology that is typically reimbursed, then of course reimbursement is very important. If you want a lead market for another field of health that is maybe more consumer driven, then it's important what kind of resources go in there. But yes, without resources, you cannot be a lead market and where you actually for a particular area of health. Yes.
Any other questions? Okay, please go ahead. Another mic here.
Thank you. Maybe more of a comment than the question, Kadi Lubi from Pfizer, but I just would disclaim that you now awaken my social scientist in me, and then I would like to just more comment that I really appreciate what you were saying about the Estonian system, and I agree fully with you. And also I very much like that you mentioned that it is more than healthcare system as such, and even actually more than health as such. My question is more than because if we are looking it more, let's say, holistically or the whole picture here, because we are often talking about and then thinking that we are talking like us as regular people, patients or persons, but often this kind of digital innovation, it's not only the issue of this patient role, but also we have to somehow help and support healthcare professionals in their education. So how wide it can be, so to be sure that really this meso level also helps this healthcare level, because maybe the patient themselves, they are ready to adopt some kind of things. The system or state provides some kind of issues that we can solve it, and everything is available, and we know how to make it accessible. But then the barriers will come from different parts. Thank you.
There are various interesting aspects in what you said. I think one is around kind of this idea of, for example, making healthy choices by default, right, in the population, so that you actually don't have that barrier, but rather kind of enable people to very naturally kind of make healthy choices in what food they pick, or if they actually take the bike to work or things like that. I think the second is also around, as you say, an aging workforce, right? Educating people, especially in digital interventions and digital help, but also I think in helping to educate people on what they actually need to do in their everyday lives. So I think it's both about this to individuals kind of reducing the barriers, but then also, as you rightly say, also for the healthcare professionals.
Very quick, two additional comments in the same direction, because we spoke yesterday a little bit about education budget and health budget in Estonia. Education is also very much a health department, if you want, right? If I think about my own education, I think I had exactly one lesson in biology once, where kind of the biology teacher gave a bunch of things you can eat, and we had to say which ones are healthy, which are unhealthy. There's an enormous potential in education to teach about health. So education is very much a investment area for health. You catch children early or people early. And then secondly, also, for example, about more classical capabilities, training educators selectively on cognitive behavioral therapy, so non-healthcare workers, on one of the most effective interventions in mental health that we heard is very under-resourced, can be very cost-effective way to broaden the base of those that can contribute to health beyond, let's say, the healthcare workers in a narrow sense.
Thank you. I mean, I can see that this actually raises new questions right now. We have another question, discussion going on, but yeah, the last question now, and then let's move on.
Okay, I have a background in public health, and thank you for your presentation. I am very curious about the sort of lack of you mentioning interventions that would perhaps intervene in designing our food environment, the environment in which addictions develop. And it seems wonderful to keep adding sort of new services or new education, but we could also look at it as, food marketing is a type of education, and in Estonia, it looks like we're now rapidly catching up to childhood obesity rates that are similar to the ones in the UK, in the US, and I'm just interested in your actual practical suggestions on how to intervene on that really upstream level of environment design that would involve potentially regulation of certain market players.
So thank you for that comment. So of course, getting practical is very important, and within the McKinsey Health Institute, a very important focus that we have is actually healthy cities, because those are smaller, more contained environments in which one can bring stakeholders together and think about how to make progress on the environment and so forth. I believe in that logic, Estonia is a little bit like, size-wise, falls in the same category with, I think 1.3 million inhabitants, right? So now, what I talked about is, yes, it is important to mobilize the private sector, and I believe there is across all industries, and I believe there's an enormous opportunity, how the portfolios can positively impact health, the products that industry can offer, and consumers more and more demand it. So consumers have a very important role to play, and also the science, how different types of products and services are impacting health is increasingly clear. So I believe that offers an enormous positive opportunity, an opportunity for growth and an opportunity for health. And there's, I think, a lot also already underway in terms of what is happening there. I'm not sure there's a clear regulatory path that is clear to everybody. We know that certain things have worked, for example, in a healthy cities context in New York and things like that. There are famous examples. I'm not an expert on that particular question of regulation.
Please join me in thanking Ulrich and Ralf. Thank you so much. Okay. Now I would like to introduce Minister Sikkut, the Minister for Health in Estonia from Social Democrat Party. She has been a Minister in Economic Affairs and Infrastructure earlier on in Kaja Kallas government, and Minister of Health and Labour in Jüri Ratas government. Minister Sikkut has also participated in our event in 2018. Thank you so much for being with us, for hearing us, and we would really like to hear from you now what are the government plans and going forward. Thank you.
Thank you. And it's very easy to come on stage and say that I agree with the previous presenters. Yes, health should be a priority in the national budget. We should invest into innovation to reap the benefits, personal benefits, in terms of living a longer and healthier life, and this macroeconomic benefits, having more people in the labor market and achieving higher growth rates. This is exactly what we want. But if you want to get a narrower picture, more Estonian-centered view, ask a politician on the stage. So, but first, to be fair, to give this perspective, of the past 32 years, I think it's necessary because we Estonians, we tend to be very critical, very demanding towards future, but we should look back and realize that we, as some of the first slides showed that we actually have made very right choices in investing into strong primary care, reforming hospital networks, making it was a random decision to put 30% of social tax into healthcare, but it has saved health from this annual budget negotiation. Health has this independent revenue, and it has enabled to make these decisions that otherwise would have been difficult to make if the decisions had to be made by politicians who are facing elections in a couple of months or something like this. We have been fortunate to have the EU taxpayers' money to invest into primary care centers and hospitals. And I don't think we have realized that this is a cost we have to cover by ourselves in the future. The administrative costs of our health insurance and the governing of the health system in general are very low. I think we are doing the world record here. The efficiency of the system is internationally recognized, and the general development or economic growth has increased tax revenues, so we have managed quite well so far. But we are facing, as it was described, due to aging, due to the low priority of health spending in the national budget, due to the workforce developments and shortage of healthcare workers. We are facing serious, I think, challenges, and we have to make political choices as well. In addition, as from coming to the last question we heard, that the environment, living environment, the choices Estonians make every day mean that the disease burden is, I would say, Eastern European. The role of addictions, alcohol addiction, that the avoidable morbidity and mortality that we have, it's somewhat embarrassing in the 21st century, and we don't really have a plan how to tackle this. We still have 4 to 6% of people uninsured, and around the same large group having inconsistent insurance status. And putting all this together and looking into the future, I won't repeat what has been said already. Very good points. But I'll share 3 stories and add something, as it's very rightly here, about personalized medicine and advantages that Estonia should take, or Estonia has already and should make use of in the future. Although here we share a common understanding that health should be of a higher priority in any budgetary process, but it is a value-based decision. So I think it was more than a year ago, I was the Minister of Economy, and getting ready for, maybe it was a TV debate or something like this. I was put on makeup, getting my hair done, and the makeup artist shared a personal story that, her friend of hers is getting married. Oh, good news. Congratulations. But she was considering marriage because the youngest of her children, the 3rd kid, was turning 3. And in the Estonian insurance system, it means that she lost the health insurance since she hadn't returned to the labor market. But if she's in a traditional relationship and officially married to her partner, she could continue having a health insurance. I'm not sure that our insurance system was designed to promote traditional family values. It's good that it does that, but it's it's not a reason we would like Estonian people to make choices in their personal life based on whether they will get an insurance status or they will lose it. So although in the political debates we see that the universal health coverage, it's something that, social democrats support because they like to spend, and others against because, let's save on that. Considering the information we saw on the slides today, I think in general, as a society, we should be in a phase saying that the overall benefits of having early access to medical treatment, if necessary, they overweight the spending on the 4 to 10% of people who we deny access in case of a medical need. So making healthcare and access part of this core social networks that carries everyone, no matter what are the choices they make in their private lives, is something we haven't agreed in the Estonian society. We see this as an important value debate, like which type of political ideology you support. We don't see it as a prerequisite for economic growth, for solving issues in terms of labor market that we can't solve otherwise. We need these healthy people contributing in the society in varying ways, and we will all be better off. We will get personal benefits in terms of better health, and we will get the economic benefits. Another story. It's about bread. It's very difficult to explain, to answer the question. For some reason, I often get, why isn't healthcare like going to the bread or supermarket and buy bread? You can take a rye bread or a sliced bread or a white bread or raisin bread. But let the patient have the choice. So why can't we achieve it in healthcare? And it's like, we should aim for that or what? But preparing for a speech on an anniversary of our, I think it was a nurses association, and it was just a few days after I got the bread question again. It's like, but we are in a situation of resource constraint in the healthcare system, and it's purely due to the lack of workforce. So if we would face the same type of constraints in the bread production, for example, whether it's lack of flour or energy or something else, that the rational decision by the government would be that, let's lose the raisin bread, let's produce the full loaves and give it to everyone who has an empty stomach. We are solving the question of hunger, and everyone should get their bread based on the objective needs. It's the same in healthcare. If you have a medical need, you should receive the treatment. And since we face resource constraint in terms of, we don't have cardiologists or mental health nurses sitting here and waiting. Will anyone have a health problem today who would like to consult me? We are in a different situation, and we will never be in a situation where we have healthcare workers waiting for the patients to enter the door. We have waiting lists. It's an issue that every developing country is trying to solve. So we should look at the healthcare and organize healthcare differently, considering the real resource constraints we have. We would make the decisions in any other industry, but for health, it's very difficult decision to make, because we are trying to govern healthcare as an industry that doesn't have resource constraint, but we are not in that situation. And the final story, because the digital prescription was mentioned here, and this is something that I have shared the most internationally, because many even doctors are skeptical about e-prescription, and also politicians. Digital, that there are, I think, privacy issues, cybersecurity issues. We need to retrain the health workers to use the digital tools. We need to invest into digitalization. So is it really worthwhile? And although I think Estonia somewhat instinctively made the decision, and we have really reached near this 100% of digital prescriptions, and I think we made the choice based on efficiency arguments as well. Let's lose paper. Digital, it's a modern way, it'll be quicker, it'll be more comfortable. And making the decisions, we didn't realize that at the same time we get new tools to reduce inequalities in the system. Because the health insurance fund realized, looking at the data, that nearly a third, or only a third, of the people who are eligible for the additional pharmaceutical benefit actually apply for the benefit. And it's not an issue that the people don't need it. Elderly people with chronic conditions, they actually need the benefit. Why aren't they using it? Because you have to buy out your prescription medication beforehand. You have to calculate your cost, your out-of-pocket costs on prescription medicine. You have to know about the benefit. You have to send an application. It can be a digital application to the health insurance fund, and then wait for the reimbursement at the end of the year. Why would we want this level of awareness and proactivity from the people who are actually eligible for the benefit according to law if we have the data electronically available? We can see each morning, who reached the ceiling of 100 euros on out-of-pocket payments on prescription medicine, or 300 euros per out-of-pocket for prescription medicine. And since the law says that after that 90% is covered by the state, why can't we do it? And we decided that yes, we can. Now, in the pharmacy counter, the patient doesn't have to know about the benefit or ask for it. It's automatically deducted from the receipt that he or she has to pay. So now, no additional cost beforehand, no application, and the awareness increasing campaigns that, if you are a chronic patient, be aware of the benefit scheme. We receive savings, and we actually deliver what we want to do. We get even better adherence to the treatment by the patient. So digitalizing a process enables us to use the digital data to redesign services and actually deliver better to the patients and achieve equity goals that are not possible in the paper-based system. And I'm not sure that many countries, even in Europe, have actually realized that. Because even this summer, we had a very interesting ministerial discussion about electronic health records in connection with the European digital health data space, European health data space. The question that should patients have the option to opt out from having the digital health records, or should it be an opt-in system that patients apply for a digital health record and then get one? It's like, why do you give patients this choice? We see that it's better for everyone to govern the system. Actually, it's better for the patient. If he or she at any time wants to connect the data of the wearable or whatever tool to the health information system that should be possible in the future, she doesn't have the past, the diagnosis, the analysis results. So even if in one point he or she decides to opt out, there is no way for him to reconsider the decision and be in equal grounds with other patients who have had the medical record for the past 20 years. So is the freedom to choose more valuable than the potential health effects from the future health system that will be digital, as we all know? I'm not sure that giving the choice to patients is in the best interest of patients, but there is no common understanding in EU, and this is one of the role of as I see, of Estonia, to prove that digital is not more dangerous or just for to achieve efficiency targets. There are so much extra that you can achieve, that the horizon widens to a scale you can't imagine. And this is being said by a person who prefers paper and pen. So personally, I'm a very slow adopter of new technologies, but on a system level, there is no other way, really. And digital therapeutics were already mentioned, and I would lastly mention personalized medicine. This is something I also feel that Estonia should take fully this advantage of. The fact that Estonians have trusted the Genome Foundation, 1/5 of the adult population have donated their blood to have their genome sequenced and so on. We should show that this information can be used in personalized prevention, in better service provision, personalized screening programs, and also guiding everyday prescribing decisions. And this is something, everything takes longer than we expect, and this has taken more than 5 years, but maybe we can deliver during the next year, and based on that, the next time we meet, maybe we have the first results to show. But I'll finish here, the details of the next budget negotiations, we can also discuss the next year. We hope that there will be political consensus because it is unavoidable to prioritize healthcare area, and for the first time, the budget strategy includes the honest view of the health insurance fund budget or growing deficit that reaches nearly 300 million by 2027, and it's the minimum. So it's a good ground for a good base for the next budget negotiations. But now I'm happy to answer the questions.
Thank you so much. Are there any questions right now?
Hello, thank you. Evita from Roche. I'm based in Latvia, but I work with the whole Baltics and have a quite good overview. I would like to say that your breakthrough really was to separate healthcare budget from political environment. That was a really smart move. And if we consider this as a breakthrough for your healthcare, do you have a next breakthrough in your mind? What you are looking?
Looking into the future, I think personalized medicine that involves using genome information and digital therapeutics, they all benefit. But if we look at the financing side in general, then my proposition on how to change the financing scheme of the health insurance, it doesn't go far from what we already have. So if the 13% are paid by working adults, the state covers the insurance costs for the elderly. So let's move and cover the kids as well. So additional budgetary payments from the general tax revenue to the health insurance, it's the easiest and logical way to solve the deficit issue for the health insurance fund. So it's not a difficult it's not necessarily an innovative approach. I think some of the decisions in the past have been right, and we can build on that. So keeping the healthcare away from the annual budget debates, but just giving it a wider revenue base. It's, I think, the Estonian way forward, and I hope you make the similar choices soon. Yeah.
Okay. Other questions? Go ahead, please.
Ludvika from Lithuania. So we are now sharing the Baltic perspective. Thank you so much, Minister, for sharing your perspective. I have a question. How do you see the priorities within healthcare budget for the next year? So what are the priorities for you as a politician and also, you know, kind of guard of Estonian citizens' health? Thank you.
Over the past few years, Estonian health insurance budget and other costs that are related to healthcare, we are trying to make the shift that has been described, more on prevention, more on designing the environment to enable people to make healthier choices, and mental health. In mental health, for the past decades, we have basically provided psychiatric care, or the really specialized treatment that is needed in some cases. But community level services, low threshold intervention, it's something that we didn't finance, we didn't provide, and we didn't even have an idea what type of services these should be, because the stigma towards mental health problems was very strong. Ironically, the crisis we have faced, COVID crisis, that brought to the fore that the mental health worries of youngsters who have faced long periods of distance learning, it somehow normalized feeling isolated or having anxiety or discussing depression due to the crisis situation, and also the Ukrainian crisis, and receiving the large number of refugees made Estonia actually implement mental health and psychosocial support. We have tens and tens of people who have received evidence-based training by the WHO through a technical assistance program, and this has been on the plans for years, but now, because of the war, we have made the step forward. So prevention, increasing low threshold intervention for mental health, and designing the living environment that help the children make healthy choices, and adults as well. These are the steps forward policy-wise.
Do you have another question here?
Thank you. Thank you for this presentation, and again, more like a comment, and I will continue in the same, like I started already previously, since you mentioned as well that you are a paper person, and then we have seen the struggles, and what I was thinking previously, that we often hear also from healthcare professionals that the art of medicine is sort of getting, we are losing it. So what to do still? Or how to yes, yeah. And then how to address this challenge. I understand that partly we have to negotiate also with universities, because they train healthcare professionals, but on the other hand we have very much practitioners, and how to make these kind of changes smooth in order to really support this digitalization, and as all the presentation have outlined, we actually need it, because we have aging population and lack of resources and so on and so on. So some ideas. Maybe
the only suggestion I have to achieve this type of behavioral change is giving these health professionals a possibility to actually experience the change, whether it's write it out the first e-prescription, or doing something using personalized medicine tool. Usually the first experience is positive enough in order to make it a habit. And this is my only recommendation coming from a personal experience. For example, my family doctor started using the e-family doctor app. So I can't call her, I have to use the app, and it took me a while, but it's much better. And I think I was one of the last Estonians who continued calling if I wanted to call a cab. There was Uber, there was Bolt. I didn't realize that they actually have an advantage over the traditional phone line service. But the first time I used Bolt app, I've never called after that, and I believe the same works in different innovative or digital solutions in healthcare.
Okay, please welcome, join me in welcoming and thanking. So now we will have a coffee break, so please be back at 11:15.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
The laws of physics, the laws of evolution, the laws of civilization, the laws of economy, the laws of life. Laws connect everything. They are the invisible lines linking events that may look distant and detached from each other, but in their essence, they are all parts of the same organism, each one playing its role for the good of the whole, like an ecosystem, like a society, like a careful choreography, where every element moves in perfect coordination with the rest, working harmoniously for the same purpose. We think that to be legal advisors, we must live under the same philosophy. Like one entity, instead of separate parts, sharing the same vision, adapting to connect, and connecting to adapt.
Chemipharm is the leading hygiene expert in the Baltic states, with more than 90% of all medical institutions in Estonia using our products. For more than 20 years, we have been developing, producing, and distributing disinfection, cleaning, and skincare products for professional use in the medical sector. It is important to emphasize that our production and quality management system is fully certified according to ISO standards. Chemipharm is represented in more than 25 countries worldwide. We work hard to meet the very demanding high standards of the medical sector. A digital twin of our main factory was created to make our production even more efficient. Our R&D is carried out in collaboration with European top scientists and universities. Quality control is assured by specialists in our well-equipped laboratories. As a result of in-depth research, we have developed a complete product range for professional use in healthcare institutions. We have created a skincare line, D-Difference, radiant skin regardless of type and condition. Chemipharm's ultimate mission and drive is to prevent the spread of infectious diseases and to help save lives. We can proudly say that this is what we stand for. Chemipharm is the leading hygiene expert in the Baltic states, with more than 90% of all medical institutions in Estonia using our products. For more than 20 years, we have been developing, producing, and distributing disinfection, cleaning, and skincare products for professional use in the medical sector. It is important to emphasize that our production and quality management system is fully certified according to ISO standards. Chemipharm is represented in more than 25 countries worldwide. We work hard to meet the very demanding high standards of the medical sector. A digital twin of our main factory was created to make our production even more efficient. Our R&D is carried out in collaboration with European top scientists and universities. Quality control is assured by specialists in our well-equipped laboratories. As a result of in-depth research, we have developed a complete product range for professional use in healthcare institutions. We have created a skincare line, D-Difference, radiant skin regardless of type and condition. Chemipharm's ultimate mission and drive is to prevent the spread of infectious diseases and to help save lives. We can proudly say that this is what we stand for.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
The laws of physics, the laws of evolution, the laws of civilization, the laws of economy, the laws of life. Laws connect everything. They are the invisible lines linking events that may look distant and detached from each other, but in their essence, they are all parts of the same organism. Each one playing its role for the good of the whole. Like an ecosystem, like a society, like a careful choreography, where every element moves in perfect coordination with the rest, working harmoniously for the same purpose. We think that to be legal advisors, we must live under the same philosophy. Like one entity, instead of separate parts, sharing the same vision, adapting to connect, and connecting to adapt.
Chemipharm is the leading hygiene expert in the Baltic states, with more than 90% of all medical institutions in Estonia using our products. For more than 20 years, we have been developing, producing, and distributing disinfection, cleaning, and skincare products for professional use in the medical sector. It is important to emphasize that our production and quality management system is fully certified according to ISO standards. Chemipharm is represented in more than 25 countries worldwide. We work hard to meet the very demanding high standards of the medical sector. A digital twin of our main factory was created to make our production even more efficient. Our R&D is carried out in collaboration with European top scientists and universities. Quality control is assured by specialists in our well-equipped laboratories. As a result of in-depth research, we have developed a complete product range for professional use in healthcare institutions. We have created a skincare line, D-Difference, radiant skin regardless of type and condition. Chemipharm's ultimate mission and drive is to prevent the spread of infectious diseases and to help save lives. We can proudly say that this is what we stand for.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things.
Welcome back, everybody. Welcome back, everybody. So take your seats and we can continue. So we have another excellent speaker and then a panel discussion to look forward to. And first of all, now I would ask Irma Weberic, General Manager of Roche Poland, to join us. Before becoming a General Manager in Poland, she has also been a General Manager in Slovenia, Hungary, and She has the background of from Faculty of Natural Sciences and Technology, Department of Pharmacy from Ljubljana. She joined Roche in 1996 as medical representative, so has really held various positions in the company and knows the industry in and out. Currently, she's providing oversight over key company projects in Poland, co-creates strategy and vision, and coordinates its implementation. So we would be very happy to hear your thoughts.
Let's do some space first. Ah, good. They said Terry, so I'm saying Terry. Dzień dobry. It's really great pleasure to be here today. It's my first time being in Estonia, first time being here in Tallinn, and I need to admit I am like happy that I get the privilege to be invited. We have a great architecture of our cities. We have meaningful history. We have good perspective in economic development. And we can boldly look to our future. What else do we have in common? Warmth, openness, and absolutely great creativity. That's what we have. And I have had a real pleasure and privilege to experiencing it in 3 countries. Majority of my time in Slovenia, in Hungary, and now in Poland. These are the features which are in our genes. But on top of it, this is the fuel to our passion, how we work together. We revolutionize things on the way we go. And let's keep this in our minds. However, COVID-19 has been a wake-up call for all of us, bringing into the center importance of healthcare, but at the same time revealing limitations and failings of the healthcare systems in our countries and also globally. So it is on us. It is on our generation to seize the opportunity and to make things much, much better. Bluntly, I think there are 2 main challenges society needs to solve. One is a climate change, and another one is a healthcare challenge. But if I put them on a pair, there is a significant difference. For healthcare, we have solutions staring to us. And we have heard from our speakers before me what is possible. So before I move to the solution mode and present a bit what could be the solutions, let's check some data. Many data were shared already today. Patients in Romania wait for access to get a therapy more than 2 years, 790 days longer than Germans. This is really the first critical data. Also about that, Michael speak a bit, and I would like to go a step further. 21 innovative therapies are available in Lithuania. Only 5 more in Slovakia. Additional 5 here in Poland, 31, and 1 more in Latvia, 32. I would say in Poland, we could be quite happy with 59 out of 168. Is this enough? Absolutely not. So not only that we don't have products, but you can see on the left side of the slides how much time we need. And in our countries, we need 2 to 3 times more time to get the reimbursement of our products. And Estonia, you know the numbers better than me. So this we need to change. Another set of data, mortality. We talk a lot about the mortality. Not only that we are dying more frequently in our countries, but we are dying much more younger in our countries. Spain, just look the number. 800, less than 800. In Estonia, almost 1,200 people, and in Bulgaria, 1,500. The difference is huge. And the last set of data, and then we move forward. GDP. Historically, we use less GDP for health than Western Europe. But we use less in the percentage of GDP spent for health, but also in the absolute number per citizen. As you can see behind me, the lowest one, Romania, Hungary, Poland, and also Estonia, we spend less than 7% for health. In Poland, we spend only 5%. The rest is a private investment. And the average is, in Europe, almost 11%. But there is not just we need more. What we need also is our systems need to be more effective and efficient. By the latest OECD data, it is clear. At least 20% of money we are paying in healthcare is useless, is a waste. So we need to check this part too. So now we have a lot of data, and willing or not willing, we need to admit the healthcare system, the healthcare financing system is broken. What guided us for many decades need to be turned around. The fundamental change is needed. The fundamental healthcare transformation is needed in Central Eastern European countries, but also globally. We are not alone. So what could be these changes? Of course, I'm from Roche, and I need to spend a few seconds what Roche is. So we are spanning our business in diagnostic, in pharma, insights, technology and data analytics. And yes, I'm pretty sure you know what we are doing in diagnostic, what we are doing in pharma. But the one part which is probably not so known to you, and I'm really proud because we are part of this in Poland, we have a strong research and development center for IT solutions. In Poland, we have 550 research and development IT experts. 21 apps were developed in Poland, used now globally. 50 million people are using it. I would like to name just 3 of them: My Vision, My Sugar, and Floodlight. And Floodlight is the one we are using for multiple sclerosis. So patients are adding between the visits what's going on with their conditions, how they are feeling. All these data are captured. And then when they have a visit with doctor can check what's going on. So I would say we are not completely traditional. We know the direction we need to go. What is unique to the entire pharma industry, and I'm not calling us anymore pharma industry. We are healthcare industry, and there are many representatives here. We are really trying to make the patient journey, and that's below the slide, working. Starting with good prevention, following with early detection and screening programs. And I have learned this part is pretty well here in Estonia. And then it's so important that we have the right diagnostic, followed by right therapy. And at the end, we need to have a monitoring, a constant monitoring, and we need to learn what's going on with what we are giving to our patient. Regarding the diagnostic, I need to say that in last few years, diagnostic improved so much. We can have next generation sequencing, comprehensive genomic profiling, but we are not using this properly. There are rare countries having the reimbursement for this. Croatia is one of them. And I hope next year, April, also Poland will have a systemic comprehensive genomic profiling. So this is something what we need to strive for. I need to speed up. Yeah, personalized medicine. We have heard a lot, also from the ministry, how important is personalized medicine. And I would like to showcase this on the oncology. The knowledge about the cancer has developed significantly in last decades. We know now that cancer is not a particular organ disease. It is a disease of the genome. Mutations happen in DNA, and that's leading to the growth of the cancer cell. That also means that two patients can have two different mutations, and that's for they need to be treated with different treatments. And you know what? We do have these treatments available. 168 registered in Europe, only 31 present here in Poland, in Estonia, 59 in Poland. So we need to start using this. The second piece is about digital and data. And here Estonia is beautifully well positioned. Because what we need to do in this revolution of healthcare is collect high quality data from each and every person, and then connecting this to the large data pools, which can be analyzed with the artificial intelligence support and algorithms. So I would say here in Estonia, you have a lot of data. We have a lot of data, but unfortunately, these data are floating around and they don't have any meaning. So what we need to do, we need to scale it up to meaningful data and then properly use this data. And one thing which we need to remember, data and digital, that's our future. The third puzzle, the third building block is a personalized healthcare. And I spoke about that already. How we see personalized healthcare can really come to the life. We need to have accurate early detection, tailored care plan, access to innovative products, innovative solutions, which are not just medical treatments, it's much more. And then this should be continuously monitored. So these are three building blocks. And then I need to spend a few seconds in what's going on here in Europe. European Union realized how important healthcare is, unfortunately, during the COVID times. However, there are now several initiatives going on in Europe. One of them is European Health Data Space. And I was thinking what to say in this slide. I don't have anything more to say than the minister said. And I hope that she will be able enough to explain the story to other ministers in European Union why it is important that all patients, all of us, are immediately into the system, because then we can leverage really what we can get out of the data. And that, I would say now, the most eager one, the most awaited one is for sure European Union pharmaceutical legislation. In last 20 years, that's the one we have it. So we were all waiting to get a new European health legislation in order to be a bit more competitive. Because, you know, 20 years ago, the most innovation came from Europe, almost 50%. Now we are lagging behind United States, and China is getting also very close to us. So in order to stay competitive and innovative, we need to change this. But unfortunately, what is currently in the discussion is moving us in different direction. IP protection, instead of 8 years, at the end we will have 6. So how is this stimulating us? So these are just two main things which are going on in the European Union, and I'm encouraging everyone in this room that we are vocal about our beliefs and that we speak with one voice, that we want to have European Union to be competitive. Yes, we are at the pivotal moment of the healthcare history. There is no doubt about that. On one side, we have medical knowledge, which is doubling every 70 days. Every 70 days. Then we have digital data, data science. All this is revolutionizing the care. But on the other side, we have aging population. We have growing population. We have systems which doesn't work. So we really need to come together and do something about it. So I was trying simply to explain what could be these 3 building blocks. Maybe they can be 6, adding also other stuff. Personalized medicine, digital and data, personalized health. So we know what we need to do. The question is, what is still missing here? What do you think? How we will do it? The problem we need to solve is too big that one will be able to solve it. We need to come together and solve the problem together in collaboration and in the private partnership, private-public partnership. One day, I hope, we will not talk about public-private partnership, but just about the partnerships which will really help us to have a bit more healthier lives. There are 2 main shifts, mindset shifts we need to do. The first one is we are seeing healthcare as a cost. We need to see healthcare as an investment, as an enabler for better productivity, for better performance of the country. And that then could help us to be more competitive. And the second shift we need to do, we need to move from managing sickness to managing health. Because health is wealth. And there were already some data how prosperity of Estonia could look if you move in that direction. And at the end, we can bridge the healthcare gap between Western Europe and our countries. But we can do this only via partnership and investment. where you live should not determine whether you live. And the last one. We are talking so much, not today, about the artificial intelligence, machine learning, digital. But at the end, healthcare is a human care. And sometimes a warm word, I'm here for you, and hug to our loved one could help a lot too. So don't forget this. Healthcare is a human care. Thank you very much. It seems I need.
Yes, Irma, thank you so much. And if you don't mind, I will already ask the panel to convene, because
so I can sit down.
Yes, you can sit down because you can. It is a good place to continue with the discussions about the partnership. So Andreas Kaju, co-founder and partner at Meta Advisory, will take on from here, and we will hear the discussion going forward. Please, panelists.
Sure. This is working, right? So without further ado, you actually know most of the panelists already, so I won't go into their bios anymore, with the exception of a few new faces who you haven't seen before. First, Laura Johanna Tuisk from Eesti Tervisekassa, as it is known now, or what's the proper, we call them the National Health Insurance Fund still in English, but unless you've developed an English trademark as well.
No, the English one stayed the same.
Still the NHIF, so that's the single payer in the country who finances most of the healthcare. I would suppose that probably about 93% of the healthcare that is covered by Tervisekassa is provided by government or municipal owned healthcare providers. Also, for context for our foreign speakers today. And the second guest who has not been introduced yet today is Liisa-Lotte Lääne from Sorainen, one of the leading law firms in the country, and Liisa-Lotte is one of the leading practitioners, legal practitioners in the medical and healthcare legal space, and will address issues from her vantage point today. So, for your benefit and for the benefit of the panelists, I have prepared some questions for this discussion, which will last for about 30 minutes, after which you will still have 10 minutes to put forth your own questions to the audience. If it really burns inside you and you have a question and you want to interject because you heard somebody say something that is outrageous, then perhaps we will let you so that you wouldn't forget your question when we reach the end of the panel. So feel free to raise your hand. We can sort of manage that here. And despite the fact that I do have my questions, which are based on today's discussion and the notes that I've made based on the speakers is presentations today, I will of course allow for a little bit of freewheeling and dealing and your own dynamics when you raise your hand and want to comment on what somebody else previously said. Feel free to do that. That's more important than my notes. But to get things off on the right foot, and when you have a minister in the panel, you sort of feel like you want to put all the questions to her because she kind of is one of the persons who has the keys to the treasury regarding healthcare, at least in Estonia, even if that treasury is resource restricted, as she put it herself, constrained. So, Minister, when you identified the priorities that you and this government has in healthcare, to me, and I suppose that for many of the pharmaceutical companies here as well, the things that you were emphasizing were very much about the more long-term benefits that you hope to gain from tweaking or changing financing and prioritizing new issues from mental health to preventative healthcare. But you didn't talk much about
what's happening now, the therapeutic side, the treatment, and what kind of additional benefits and return on investment can we expect in the near term? And I think this conference very much has tried to build the argument that there is direct return on investment, and that's kind of the change in the framework of thinking that we need to get to. So what about those short-term changes in treatment, innovative access to innovative medicine and therapeutics in general? How do you feel about those issues and address those here?
Unfortunately, I don't have the keys to the treasury, but there's an easy way out from this question. The reality in Estonia has been that it has never been down to the political decision making when we discuss the access of different pharmaceuticals or medical devices. It has always been down to expert decisions, and I think it's the right way to go. And someone asked about the 30,000 euros per Kali criteria. That is, we are in the process of reviewing it. It'll be more flexible, and I understand the constraint that it means to many patients and access to their life-saving treatment. And in the future, it will be an expert decision. So I encourage the discussions, but the decisions on the political level, they come down to finances. And the questions I received most often from journalists are the two issues that you didn't mention. One concerns the end-of-life care and support. When we look at the current needs, there are 2.5 centers that offer palliative care, but we have more than 10,000 people every year all over Estonia who are at the end of their life, who need pain-free days, who need mental health support, care services, and this is something we haven't financed and we cannot provide for them. I think it's a giant leap we need to take in the coming years, and it's connected to the discussions about euthanasia and assisted suicide, and I think it's the first coalition agreement that ever mentioned end-of-life support and the dignity to make decisions about the way you want to live this world. And the second question I get most often is, it's surprising because we didn't discuss it during the coalition negotiations. It hasn't been mentioned in any coalition agreement. It's, are we planning to legalize cannabis? No, the government has no such plans. But this has a lot of public attention, and this is a question I get a lot.
What's on voters' minds is on voters' minds. And that's right, you probably don't get a lot of questions about financing of therapeutics from voter meetings, and that's why we need to have conferences like this to raise these issues onto the agenda. Ulrika, given what the minister just said about, she stuck to her own guns here and to the answers that she gave in her original presentation, in the context of what you and Lars presented today regarding the sort of more holistic thinking about healthcare investment, how would you comment on the Estonian government sort of emphasizing right now the more long-term investment vehicles in healthcare and the long-term vectors of influence to produce better health outcomes rather than put more emphasis on treatment now, which we can see also from the access to innovative medicine table where we are lingering in the bottom.
Yeah, well, I think short-term and long-term and treatment versus prevention are not necessarily the same axis, right? So I think it's totally right to move from, as you said it, from sick care to health care, because today only, if you look at the global average, only 3% of funds actually go to prevention. So I totally encourage the move from treatment to prevention, because I think this will really move the needle long term with all the social benefits and economic benefits for the country that we talked about. But I think at the same time, it's important not just to say, let's solve that problem, not that you said that, but like, let's solve that problem in like 20 years, but rather kind of think of immediately influenceable interventions, 3I, that can be done now, that change something in the short term, but have that long-term view that really moves the needle.
Lars, first, if it's a comment or a reaction, then Irma, please go ahead.
It's a reaction, if
sure.
I may.
Yes, that's what I'm hoping for.
And it's, I'm happy that we start to speak about movements seek to health. But still, I need to emphasize the importance of diagnostic, a proper diagnostic, and the importance of proper medicine treatment. Because you know what should be our aim, that the right patient will get the right treatment at the right time for the right value. And this, you know, with the diagnostic and medicines availability, it's a short term, but could boost our economy significantly. I know that you need to have these trade-offs because you don't have like unlimited budgets, but I just want to emphasize how important this piece is also in this entire patient journey. And for the screening pieces, I'm so happy to hear what you are already doing, because that's the case. Again, Minister, it's good to emphasize on the European level. Just example, because we are now in October, Breast Cancer Month, screening in Poland for mammography. What do you think, how many women in Poland react to the invitation? Here is 80%. In Poland, only 30%. So, you know, these are the things we have to do in our country. But it's important that whatever we can do, we do in parallel, and we don't do the priorities exactly. It's an art, but we need to keep all the time this in our mind. Sorry. Just this.
A logical follow-up question based on Irma's intervention would be, of course, that if we know that there are interventions like screening in breast cancers, which Estonians react positively to, in the sense that they react to call-ups and go and have it checked, and it produces great immediate outcomes for the healthcare system, early detection and so on, you know, is that something that we should do in the vein of what Lars and Ulrike said in their presentation, that let's leverage, you know, known evidence-based interventions and scale them more and more and more if they work? Maybe Laura Johanna, because it's kind of in your budget, screening.
As everything else in our healthcare. But it is true that before, of course, innovation is very important, and we have to always reach out for better solutions. But at the same time, we have to bear in mind that we have to do the most logical things that we also haven't really applied in our system. The same topic, for example, screening for cancer, definitely should be higher in Estonia, and this is one thing that we know for sure is a great benefit for us all. So definitely we cannot really put them to the side, because everything new always seems like more exciting and hotter, and maybe it will like rid us of all our problems in the future. But there are things that we know that work. Same with lifestyle diseases. We know what the risk factors are. So even when you do like the genetic sequencing, and you tell someone that you are in high risk for, say, breast cancer, and we know that for breast cancer also a big risk factor is obesity, then if this person already knows that obesity is a risk factor for like tens of other diseases, then getting to know this fact from a genetic test, does this actually affect them to make a change in their life? So there are things that we know we have to address now that will affect many, many different diseases.
I think this is one of the questions we should be able to answer in the future. For me, it's very interesting to personalized recommendations based on your own genetic data work better or motivate behavioral change better than these generic recommendations. I don't know whether they work better, but this is something we are one of the first countries that are able to answer to some extent.
It works as Spotify. Personalized recommendations. So, Lars, do you have any feedback on that? Whether personalized recommendations in medicine would work better? And do you have any research into that already?
So, first of all, one thing that we can, I think, all agree on here, that more diagnostics is essential. We mentioned already breast cancer. There are many more, right? So there are many more of these immediately scalable interventions. We also have the whole cardiovascular space. There are many tests that are very simple, where there is in some ways already a personalized recommendation depending on what blood pressure, glucose or lipid level you have. Much more can be done with this, and the interventions that follow that are often very, very cost effective, to be honest, that then can be triggered by that. And not enough is done that is in some ways already personalized. What is definitely true is that a person, and there we are only at the beginning really, that whatever the diagnostic finding is, particularly when it pertains to lifestyle interventions in some shape or form, or even regular taking your medicines, a personalized communication of that is helpful, but we are only at the beginning. But I believe large language models are really have an enormous potential over time to also personalize the transportation of information to the individual, where it will be therefore a personalized recommendation, even if it's not part of a genetic test or so. That's a whole different element, which obviously also has its value. But like the communication is an enormous potential.
I think one of the issues that really came up strongly, especially from actually the first presentation from Michael, who couldn't stay with us for the panel because he had to travel on to another event, was a very particular call to action, I think, which signifies the importance of today's conference as a whole, was to position healthcare as an investment. And we've had some chats yesterday and also today of the enormous challenge that this actually poses within the constraints of actual fiscal planning, which takes place in either 1 year chunks or 4 year chunks in the case of Estonian 4-year budget strategy, where you simply are not able to factor in or show or demonstrate in a practical sense what the return on that investment is. So it's one thing to say that let's position healthcare as an investment, but what does it actually mean or could mean in a legal sense? And maybe Liisa-Lotta, you can sort of help us out here. What are the opportunities we should pursue in looking at the sort of regulatory or legal framework? Can we help ourselves out here through either amending existing regulation or within existing regulation already?
Well, as you said, the law gives a framework for implementing our ideas, for executing our ideas. And yeah, I would say that in Estonia, as Minister correctly said, that we have committees. And the committees, in the committees, experts are making decisions whether this medicinal product should be in the reimbursable products list, etc., etc. And we have, I would say, in our existing legal system, we have the building blocks. We have like general principles of law that we should act upon, and we should be able to put together all the right pieces, like Lego. But on the other hand, in practice, we see that very often we lack of transparency when the decisions are made. Maybe we don't even demand this transparency, because very often it's easier to stay in the comfort zone, and well, it has been done so for years already. And I think previously you mentioned somebody in the keynote mentioned that, yes, we have done it for years. We have had this system for years. For example, in Estonia, we have, like in many other countries as well, we have this pay-for-service system, basically. The hospitals, the pharma manufacturers, healthcare sector, yes, not pharma industry anymore. And we all have had to put ourselves into this system where we get paid for particular service. But my question is like, how can we then move to pay for value? Because ultimately, if we talk about this, that our ultimate goal is to be more healthy, to have this more healthy employees for longer term, then we need to look for the results and not concentrate on only the service. And I think here the legal system can very much give a helping hand, because if we change our existing paradigms, then we can move forward to the more healthy society, more profitable society ultimately.
Ulrika, please, first, and then Lars.
I think the key for actually moving to that from paying per service to outcomes-based, I think is really in the data, right? Bringing together that activity and outcomes data and seeing what works, and then supporting that with the legal and with the reimbursement mechanisms. Now to your original questions around the investments, I think there is even a number. We mentioned the $2.4 per dollar invested, but the challenge is that it's not necessarily the one who spends the $1 gets the $2.4 back. So I think, and we see that in various places in terms of drug development, but also in terms of prevention. And I think that's something to be solved on the country level to get these incentives right.
Lars and then Rina.
So, just in a similar direction on how one can really think more about health as an investment. I'm first going to say something about something I know about and then something that I know a little less about, but it's very important. So first of all, information, as we just said, is absolutely critical. Going back to where we talked about how to think about health, just asking the audience, if you go to your doctor, you neither have a risk factor or a disease at the moment, and you ask how healthy am I? Your doctor will likely say, so I answer the question directly, you're fine. However, how you actually are in terms of how good your functional health are you aspiring to do greater? How is your physical ability? Can you run around the block? All of these kinds of elements are very predictive how your long-term health is, meaning we have very little information about what the status of population health actually is. We only know about disease and some risk factors. So now, if over time, and maybe I don't know, maybe Estonia is a good place for that, we have better information about health, then we can make the link, and now I'm getting to the topic where I'm not that familiar with, how we can actually, from a fiscal perspective, treat the health of the population as an asset. Right? So there are these conversations about national health accounts and so forth, because then you can say the investment into prevention today may not show up in GDP today, but is actually I'm investing, if you want, in a national asset that is quantifiable. So there are thoughts on this. I believe Dame Sally Davis, the 10-year Chief Medical Officer of the NHS, she was now at Trinity College, Cambridge. She, in her book that she wrote mentioned something like that, and some other experts too. But there is a vision for that, how to do that also from a fiscal perspective. But first we need better information about health. We are only at the beginning there, really.
Actually, some political parties in Estonia in the history also have talked about the national personalized healthcare accounts and national healthcare accounts in order to get it more quantifiable and to look at the investment side of it. But it's been more of a center-right argument, and the center-left has usually opposed that because they've thought that it's a sort of a shortcut to some kind of a privatized, crazy entrepreneurial future. So
no, so that's not what I meant to say. It's much more. I'm not talking about like the individual being responsible for that. That's a completely different argument. I'm more thinking about what I was referring to, how the health of the population can be an asset that's investable, and that's currently not the case. So very different bend to the same argument.
Riina, you were next, please.
Yeah, I wanted to comment with a bit of humor. Liselotte very rightly said that outcome or value-based financing is something that we should aim towards in healthcare, and I agree. But what really could transform healthcare financing is outcome-based voting. If the election results would be dependent on how many lives a politician has saved, well, that would transform or prioritize health considerably. But now you asked about the long term, how to make the long term gains more tangible or something that is an argument in the budgetary negotiations. But we are far from that situation. Even the short term gains are not an argument. If we look at Estonian data, alcohol consumption. For the past 5 years, the per capita liters consumed has gone up, and we see that the number of direct deaths connected to alcohol abuse jump up. 50 more deaths per year, 50 more people who we lose due to alcohol every year directly. This hasn't changed the priorities in terms of excise policy or any other alcohol-focused interventions. If you make the same way the deaths climb up, you see the direct benefits of liters consumed during the year and the health effects. It works the other way. The liters that are not consumed during the year will provide health benefits in the coming next budgetary year and the year after, but we can't capitalize on that. So, and now we are discussing how to take into account the long-term benefits. Well, only outcome-based voting.
Liselotte, you were next, please.
Well, yeah, I don't remember anymore what was the thought back then, but like following Minister's thought that I think we actually can already see the long-term benefits in case we would be able to build up a society where the investors, the possible very high-valued companies can see that Estonia is a very good place to come here, to invest here, because the people live healthy here. Like, for example, we already have startups that sell basically virtual forests for clean air. So why can't we do it basically with health? But just this went far from the law now. But from the law perspective, this bringing data together in order to provide more personalized solutions and in order to actually maybe be a companion to a person from the birth until then to the end of life care. Basically, this requires also political vision, political input and legal changes, because maybe even considering the current definition of healthcare, because we are not speaking anymore about this traditional healthcare term. We are speaking about that some doctor calls me and says, "Hey, Liselotte, you're now in this age that you should come more often to the doctor." Why not? That would be great in my opinion, but maybe it would require more wider support from the political level as well.
Estonia has a great primary care system, but only if you're sick and you know that you are. Laura Johanna was first, and then Irma.
Well, now I should protect the family doctors because I trained to be a family doctor. But this actually connects to my thought that I wanted to say regarding Lars's comment. We have a huge demand for doctors right now. So I think it's fair and it's okay that what doctors know best is diagnosing and treatment. For example, in family medicine, right now we have almost 30% of our family doctors are 65 or older. This means that even though family medicine will always be the cornerstone of the system, we still, everything that we come up with, for example, prevention is a very logical place for primary care, of course, but we cannot give it to doctors because they have other things that they are best at. So we need task shifting, which also brings us to the legal space because, for example, right now in a health insurance fund, we are only allowed to pay for treatment. So prevention is not a thing that we're allowed to pay for, even if it's, well, okay, maybe primary care is a bit of an exception now, but mainly we are talking about treatment. So we do need a lot of changes in the legal space too for that.
Irma, please.
I lost myself because I forgot what I want to say, but nevertheless, I'm happy that we discussed that we need to move from paying for box toward value-based healthcare. That's the direction we need to go. But then you said Spotify is able to do it. And I said, yes. So let's learn from the industries which are really able to gain and transform all our interactions we have with the system, either be it Spotify, Netflix, or Amazon. You know, they are really leveraging all our interactions and they are adopting their services as we go. So can we imagine that we will be able to use real-world data, molecular informations we are gathering from next-generation sequencing, variables which we have, all the apps we are using, all the clinical data we have for the particular patient, and then we will really be able to adopt and personalize for each and every patient. And then I am dreaming, you know, one day a GP will open the file, everything will be digital, and he will see all the history. And then the things will be easier for him and also better for patient. So I know that I'm now dreaming, but we need to have a bit of dreams. Yeah.
That's not very utopical in Estonia's sense.
So that's why I use this. And I'm again looking to minister. Just speak up during the other ministers, because somewhere we are still living in the Stone Age. Because we are using, you know, it's at least in Poland we are discussing a lot, are we digital or not? We need to do a new assessment. And in one of the roundtables, the latest one, I said, why to do the assessment? Just ask the simple question. And the question is, are you using fax machines? If the answer is yes, Stone Age. That's it. It's so simple.
Lorana.
So I wanted to comment about the Spotify example, because I was thinking that Spotify will only give you the recommendations list, or it will only target you if you're already using Spotify. But the question is not how we get to the screening programs. How do we get there to people who are already a bit anxious about their health? There are women who go to gynecologist every year, which is not necessary. And these are also the women who always participate in the screening programs, although they don't even need to do that anymore because they have had all those services already. But the question is, how do you engage the patient that we don't even have the data for, because you never get to them? Like a family nurse or a family doctor might call them day after day, and the patient will just get angry. Like, why are you bothering me all the time? I don't care about my chronic illness. So I'd say even if we have the best solutions and the most innovative programs, if you don't get the patient to participate, then it's not worth it.
Awareness.
Yeah.
Ulrika, please.
It's absolutely, there's a lot of selection effects in that. And I think actually, I personally, I spent a lot of time in looking at how big data can be used for dementia research. And what we looked at, for example, is how loyalty card data from shopping can actually give you insights on whether this person has early signs of dementia. And it can also be used technically, not only loyalty card data, but like broader data can be used to predict and to also see what were the signs of people who actually then developed something later. And now I know dementia in pharma or in the healthcare sector is like a big topic that won't be resolved for years. But I think it shows the way that we need to go for going beyond the healthcare system to find these early markers and not to put more load on doctors, because as you rightly said, they are fully consumed with like treatment and early diagnosis. So that's the balance to strike here.
So we have about 2 minutes until the end of the panel before we'll turn to you, dear audience, so you can have your questions ready. But I'd give everybody 15, 20, 25 seconds for a final remark. What's your main takeaway from today and main message to today's audience on this subject? Feel free to move in any which order you want to.
Happy to start. So thank you for inviting us to Estonia. So what I'm taking away is that this real advancement that Estonia has in digital in general, like how can one leverage that, step ahead for the discussion that we've been having in a much more effective way? Maybe what is the next, I don't know when that started in the 1990s or so, but what is the next S-curve, the next horizon there, how that can really benefit the health of Estonians?
Maybe I can continue from here, because I very much agree with Lars, and I think the next big move is to bring the data that we have collected in the Estonian healthcare together for bringing innovation on the market and then bringing the innovation to the patients ultimately. And I want to reach out to all the stakeholders here in the here in physically but also online, that please demand transparency from the authorities and from the expert committees, and also patients should demand this transparency very much. Like, how are the decisions made? Why is this medicinal product right for me? And if it's not, then we need to go and demand the correct one. Sorry.
Laura, I do feel naturally to go on from there.
Didn't take it personally. But I think my takeaway is actually, well, since we're talking about innovation a lot, then the number of 6.7% of GDP is just depressing. So there's no, of course, there are a lot of changes that we can do without money, like improving the relationships within the sector and so on. But if we don't even have the money, if we don't have the budget to even cure the people that are sick currently, then we can only dream about innovation and thinking about shifting towards prevention. So now you can continue with the minister.
Irma, Minister, Ulrika?
I think it was Minister, because I understand more money is coming.
Yeah, more money is needed, but I was very got carried away with the Spotify example, because and the question, how do we reach people who are not Spotify users? And I think actually the flexibility and the person-centeredness or personalized approach is something we have to use for them as well. For example, if I realize that in addition to the fact that I'm in 0.0% of the top Sander Mölder listeners according to Spotify, if I also realize that I'm the top 1% of cookie buyers in the local grocery store, well, I may get a different perspective. But we have a group of vinyl record listeners, so for them, maybe it's the record store seller who should approach them, because they're afraid of the white coat. They have a very traumatizing experience with a dentist or some other healthcare provider. So we should not put the burden on the family doctor that it's your role to bring this patient into your office, because maybe we don't need that. We need a different approach. Someone who's outside of medicine, it could be an employer, it could be a peer, maybe it's a very competitive person, and so a friend says that let's have the step or whatever, how many kilometers we can run per year. So you have to find what motivates this specific person to change their behavior or accept evidence-based advice, and it could be advice from outside doctor's office.
Sure. Irma and Ulrika, you're the two last ones left for the final remarks.
You can go.
Well, I'll take up your theme actually that you said about dreaming. So I think dreaming big is important here. Estonia has done it once, and maybe I think Estonia wasn't even aware at this point in time that it was such a big leap that that other countries would look up to. So I would just encourage you to really kind of use the great foundations that are out there to do something for Estonia, but also as kind of dreaming big for Europe and maybe the world overall.
And Irma?
Yeah, I have 3 points. And I would go with the first one, collaboration and partnership. It is clear, open as here it is. And the question is, what are those things Estonia can catalyze in Europe in order to move things, and other two are more funny. So collaboration and partnership, this we need to keep. And I'm observing this panel now since the beginning. For sure that's the most colorful panel ever. And I think having colors is good. And the second one, you know, coming from Hungary and Poland, usually it was 1 woman, 5-6 men. And today it's different, and and it's good that we are keeping this diversity and inclusion, and I have high hopes that health is in a good hands because we have so many women also working for that.
Thank you. Let's give a big cheer. Big cheer for our panel. But now we still have about 10 to 15 minutes for the questions from the audience. I hope you have some. Otherwise, it's going to be an early end. Yes, there's a hand. Daniela.
Thanks a lot, Daniela from AstraZeneca. So the first one, just to the minister, I will never forget those 3 stories, especially the first one, so thanks for sharing. On a more serious note, you said that the next breakthrough in Estonia is precision medicine. And I hope Estonia will lead like in digital arena. But then the question might be for yourself and maybe for Laura, Johanna, what is the next breakthrough that needs to happen in the financing system? And you said, and we are aware, some flexibility will come to ensure once when we identify those patients that they have access to most innovative medicine. So maybe just a short reflection from your end.
Financing question for me and Laura, for me it's just increasing the volume or the share of the national budget going towards health, and for Laura it's rather how to spend the money to get the most outcome for the patients. So.
Well, we are regarding the efficiency level in Estonia, then I think we have pretty much maxed out on the efficiency, but still the question is whether we, as we talked, whether we incentivize the piece of work or we incentivize something else, but it's very difficult to pay for the value or pay for the outcome. So we are now only taking the first steps towards it, but it's clear that it doesn't really happen in a day. To really make the shift. So in primary care, we are in a better position. We don't pay fee for service mostly. And I think it has its pros and cons, but I think we should maybe not lose it in primary care, but instead try and move towards something similar, having like a capitation payment or whatever in other areas besides family medicine too.
More questions, please, to our valued audience. A gentleman from Medtronic.
Yes, hi again. My question is about interactions with other sectors. For example, we know that the hospitals are one of the biggest employers in the area. So it's not about, and in general, health sector is a huge employer. And sometimes when you want to, for example, subsidize and solve the issue of youth employment, maybe you can think of motivating them going to work, to try to work in the hospital. And it's not about decreasing morbidity, mortality, increasing productivity and gaining something in 20 years, but it's really some political interventions today where you see the impact tomorrow. So Estonia is extremely innovative country, so it would be nice to hear if there are something happening around this topic. There is a really nice publication of WHO, Health for All Policies, which emphasizes that we need to switch, because otherwise they don't listen to us when we are demanding health in all policies, for example, in education. It really, now there is evidence it's not working that good. But when we offer something, when we are proposing health for all policies, when we demonstrate that, look, we in our sector, we do this, and then you gain such benefit already tomorrow, it might work better. So maybe you can name a couple of examples if you have things.
Yes, health in all policies is something we strive for. But I say it's extremely difficult. For example, in the education, their main goal is academic achievement, and no one can substitute or take this role away from them. But in addition, that how much students move during the school day, what's the school lunch, these aspects have to be higher in their agenda. I can't say I have these, I don't know, positive examples of, I don't know, large-scale national policies, but smaller, whether it's programs or pilots, for example, Liikuma Kutsuv Kool, a project that puts more physical activities into a regular school day, whether it's during a math class or a specific break that offers organized play options for kids. So we have very positive examples from that. Also kiusamisvaba kool, bullying-free school. So that improves mental health of students and changes a lot of the dynamics in the school during the school day as well. So we have positive examples from several sectors. So the question is how to scale them, as we discussed with every innovative approach. The same applies to other sectors as well. So. But if we talk about young people working in healthcare or the role of healthcare sector as an employer, I would say it's encouraging to see that all curriculars that are somewhat related to the healthcare or health system, they are very popular among young people. And we should make use of that, because if young people see it as a good way for their a good sector of their future career, we have done something right. Yeah.
I'd like to add that it is true that regarding the gap in workforce that we are expecting in the next few years, then actually we don't really have anything to fight it right now. In my team, since I work in a family medicine service, in my team I have one person who is trying to, at least among the medical residents, is trying to popularize family medicine, but this is not really popularizing like medical professions altogether. It should start earlier on, because if someone already decides in like high school that earning money with TikTok is a lot easier than studying to be a doctor, then we are too late already. So we do need to change it earlier on, how to popularize it. And from my position, the question every day is also how to popularize family medicine, and we are actually struggling it with every day.
Lars?
So just a reflection from a conversation that I had in Southeast Asia, where, to be honest, there's much more attention already on the broader thinking about health across, let's say, government departments and so forth. So so that conversation was under Chatham House rule, and the health minister there was actually writing a health strategy for all of the other departments. I'm not aware that this is something that would be expected or permissible even for a health minister in many European countries. Maybe you are doing it in Estonia, I don't know, but like that I found really interesting and inspirational, because it's one thing to write it, but it's the other thing that it's also received well by the other departments, which in this case was the case.
Thank you. We've successfully concluded our conference today and went over the allotted time already. I think Lars's final comment kind of wraps it up very well. And the minister yesterday evening also said that the issue here in Estonia is that the 3 national priorities in the last 32 years do not contain the word healthcare. We have defense, we have language and culture, and education, which have been able to garner all of the political attention and the resource, and have been able to move with less constraints into the future. But healthcare has not been among those 3 priority areas, and I suppose the easy way to wrap today up is to conclude that the only way to solve these major challenges is to be able to achieve moving healthcare into those top 3 focus areas. Only then can we start sort of drawing the healthcare strategies for other departments, so to speak, in a more specific or in a wider sense. Thank you, and Elo, do you want to say any final words?
I just want to say thank you. I want to say thank you to Minister Sikkut for sharing your views and for staying and hearing. I mean, this is the partnership vision that we all have. Thank you so much, Irma, Ulrika, Lars, for coming here. Thank you, Laura, Liselotte, for sharing your thoughts, also to Michael. And we cannot leave this room without thanking 2 other persons. And I will.
Yes, absolutely. So before closing today, on behalf of the rest of the organizing team and on behalf of the AmCham board, I would like to thank 2 absolutely amazing women who are actually behind organizing that event and ensuring that the AmCham Healthcare Conference continues to be the best, the most reputable healthcare conference in Estonia for already 5 years in a row. So Daria and Tina, please would you come here?
Thank you so much, Hanna. It's actually quite unexpected, but thank you. It's much appreciated. Also from my side, a huge thank you to all of you, because we've been in touch throughout the last few months and arranging all of this. And you took the time to be here today for this very important discussion. I'm sure the discussion will continue. I'm sure that we'll take it to the next level next year. And a big thank you to the organizing team, because without you guys, we wouldn't be able to do it. So a huge thank you to all the sponsors you see over there. You made it happen and you helped us make it happen. So thank you, and until next time. And thank you, Andres.